Good evening. I'm Michelle Leifer. I'm the director of the USDAN Institute for Animal Health Education at the Schwarzman Animal Medical Center. Along with my colleague Kimberly Young, I'd like to thank you for joining us for tonight's event, Cushing's Disease, with Dr. Dennis Slade, specialist in AMC's Internal Medicine Service. This webinar is for informational and educational purposes only and is not intended to substitute for professional veterinary medical advice, diagnosis, or treatment. If you have questions or concerns about your pet's health, it is always best to consult your veterinarian. Tonight's presentation will be recorded and we'll send out a link tomorrow in case you miss anything or would like to share it with a friend. We'll be taking questions via chat and we'll dedicate some time at the end of the presentation to address as many as possible. And now it's my pleasure to introduce tonight's speaker. Dr. Dennis Slade is a board-certified specialist in AMC's Internal Medicine Service. He's also AMC's Director of Postgraduate Education, Residency, and Specialty Internship. Dr. Slade earned his veterinary degree from Cornell University and completed his residency training at the University of Pennsylvania. He practiced internal medicine outside of Washington, D.C. and in Brooklyn, New York before joining AMC's Internal Medicine Service in 2016. We are grateful to have him with us to lead tonight's event. Please welcome Dr. Dennis Slade.
Thank you so much for that introduction. I am going to just be silent as I figure out my screen sharing and make sure that's working. And it looks like that looks good.
Looks good. Thank you.
Okay, excellent. Thank you again, everybody, for taking the time to learn a little bit more about Cushing's disease. And I am also just adjusting my frame. Perfect. To answer the question that's probably on everybody's mind, dress shirt, but scrubs. So just trying to look a little bit fancy for everybody. We have a lot to cover, and so I'm going to try to do it in a timely fashion. And while it may be enticing to jump right into the heart of the matter in terms of how Cushing's disease affects our pets, I think it's really important to always understand the historical context of a medical condition, because I think it helps me understand it. It helps appreciate the legacy of a disease or a condition, and I think it just is a responsible thing to do. So Cushing's syndrome or Cushing's disease is an eponym, so it's referring to a disease process first described by Dr. Harvey Cushing, who's a very famous neurosurgeon active, as you see, in the early 1900s. And the sentinel case, the first case of Cushing's disease, was a patient that he saw by the name of Minnie G, who was a 23-year-old woman. And his notes described a syndrome of painful obesity, hypertrichosis, so excessive hairiness, and amenorrhea, lack of a menstrual cycle, with overdevelopment of secondary sexual characteristics, accompanying a low grade of hydrocephalus, water on the brain or fluid in the brain, and increased cerebral tension. This was initially thought of as what's called a polyglandular disorder. It, for a while, was referred to as pituitary basophilism, which is more of a descriptive diagnostic, and ultimately became known as Cushing's disease. And so if we were to look at a patient, an exemplar patient with Cushing's disease, on the human side of things, you can see listed some of the clinical findings that are noted. And if you ever look up Cushing's disease or see medical images, that concept of a big moon-faced person with droopy eyes and thin skin and in general ill thrift often is conjured or is seen. Over time in people, there's that excessive hair growth, which was mentioned. Osteoporosis can lead to painful pathologic bone fractures, susceptibility to infections, concurrent risk of diabetes, peptic ulcers, and hypertension. And so with that framework in mind, let's talk a little bit about Cushing's disease in people, in dogs. So we will be talking mostly about dogs tonight. Cushing's disease is something we can see in cats, and so I'll intersperse kind of some point counterpoint, so that we can have that situational awareness. But primarily, this is a dog we see with canines. And so Cushing's disease is a disease or a syndrome that we notice when we see an increased amount of cortisol production over time in our patients. So cortisol, steroids, glucocorticoids, stress hormone, we're all talking about the same thing. And over time, if we have a patient that is exposed to larger or more amounts of steroids than they should normally have, you will see pretty predictable changes in both their phenotype or appearance, blood work changes, and most importantly, clinical abnormalities. And so hyperadrenocorticism, I will use a lot of terms interchangeably, is a more medically appropriate term for Cushing's disease. We have an overactivity of the steroid made by the adrenal glands, the adrenocorticism. And so you see that diagram of that classic picture of a dog where we can have that pot-bellied appearance, hair loss, often a symmetrical hair loss, sometimes pigmentary changes to the skin. The skin itself can become very thin and often brittle. We can have poor wound healing and very predominantly increased thirst, increased urination, often an increased appetite or a ravenous appetite is what we're going to see with most of our classic dogs with Cushing's disease. And so this was first described in the veterinary side of things in 1939, so about 30 years after it was described in human medicine. So a couple of words about nomenclature. I will use the term Cushing's disease pretty liberally in this lecture. We should recognize that a more appropriate term is Cushing syndrome. Syndrome refers to the constellation of clinical signs and changes we see as part of a one disease process. And I'll also say that we should probably not even call it Cushing's disease. We should have less of a reliance on human medical eponyms for many reasons, including the fact that it may emphasize a more Western-centric reference point, because there are differences between species. And so Cushing's disease, as it refers to people, is similar, but not always the same as in veterinary medicine. And the general move away towards human eponyms is kind of in process. We don't have a lot of veterinary eponyms because Bella's disease, Bailey's syndrome, Luna's condition, very non-specific. So whether I say canine Cushing's disease, Cushing's syndrome, hyperadrenocorticism, I'm talking about the same thing. Okay, so first we need to understand what cortisol does. And cortisol is going to be critical for all of our organ systems for normal housekeeping, or what we'll call constitutive function. It will be very important, and we will need it in larger amounts as the body's normal response to long-term stress, including the physiologic stresses that can occur due to infection, inflammation, periods of starvation. As I had mentioned, clinically, we often see an increased thirst and urination because of the effects cortisol has on the kidney in kind of promoting more dilute urine. So you're always peeing more, getting a little bit dehydrated and drinking to catch up. These types of hormones are catabolic. Catabolic, they break down muscle, they increase fat storage. We're kind of going into an energy saving mode. And that is in opposition to anabolic steroids, which would be what I always call bodybuilder steroids that increase muscle mass. And so that breaking down of muscle over time leads to that pot-bellied appearance that we can see because you're losing your abdominal muscles for animals that are standing on their feet. We're having an increased redistribution of body fat. We're seeing a temporary organ enlargement in organs like the liver and the spleen, and that can lead to that pot-bellied appearance, which is pretty classically discussed. Steroids play a role in a huge role in its communications with our immune system. And so steroids based on essentially dosage can have anti-itch effect, anti-inflammatory effect, and then in really high doses, immunosuppressive effect. Cortisol, you see, can also increase blood pressure, can cause changes in hair coat growth, skin characteristics, causing that thin skin, bruisability. And so all of these things are under the umbrella of what does cortisol do? In order to know abnormal, we need to learn normal. And so let me just pull up my little laser pointer. And so this is just an example of what we call the HPA, or hypothalamic pituitary adrenal axis. And this is the main feedback mechanism where steroids fit in. And so I don't want to be overly detailed, but I also want you to understand the underpinnings of things. And so this refers to this axis where your hypothalamus in your brain will release a hormone to the pituitary gland in the brain. And when it sends out this hormone, that CRF, or corticotrophin releasing factor, the pituitary gland will then release another hormone called adrenocorticotropic hormone, ACTH. And the adrenal gland hears that signal and then starts to make cortisol in response. So there's kind of a checks and balance system. With all of our endocrine organs, there needs to be a feedback loop. We know how to turn on the machine. We need to be able to turn off the machine. And so cortisol will have that inhibitory effect on both the pituitary and the hypothalamus. So we should have, when things are working normally, a need for steroids, a way to turn on steroid production, and then a feedback mechanism to turn off steroid production. So that's what normal looks like. With Cushing's disease, there are a couple of different ways that this can develop. I'm going to talk to you about the two most common ways that develops naturally, and that's listed on this diagram here. So this is taking that same concept as before, where we have our pituitary and our adrenal gland. We're just cutting out the hypothalamus. It's not part of this discussion right now. So we have our pituitary gland, we have our adrenal glands. So the two common forms will include pituitary tumor, pituitary dependent Cushing's disease. And in that scenario, we have a small tumor on the pituitary gland that is constantly telling those adrenal glands to keep making that product, keep making cortisol, keep making cortisol. The adrenal glands are doing their job, they're making cortisol, but the pituitary gland is not listening to that signal saying, hey, boss, we done our job, we can stop production. The pituitary gland doesn't have that feedback inhibition. And so we just keep on getting the signal to keep on making cortisol in excess. And so again, that is pituitary dependent. The other type is adrenal dependent, or an adrenal tumor, in which case we have a tumor developing on one of those adrenal glands, and it is producing cortisol willy-nilly. It is doing it of its own accord, and the rest of the body is saying, shut off, we're making too much cortisol, but the adrenal gland doesn't care. It's a tumor, it's going to do what it wants. So those are the two most common ways that dogs will develop Cushing's disease endogenously. So that pituitary form, a little bit more about it. We can also use that term ACTH dependent form because it is producing too much ACTH, which is that hormone that tells the adrenal glands to make more cortisol. This is going to be the most common type of Cushing's that we see. It happens in about 85% of cases. Often, and it's important to know, often when we talk about a pituitary tumor, it's really small. Most of the time, they are what we're called macrotumors, microtumors, so they're less than 10 millimeters. But we can see growth over time in some patients that will develop a macrotumor where it is a little bit larger. And that can have implications, which we'll talk about. In terms of histology or what is happening on a tissue level, with pituitary-dependent hyperadrenocorticism, most of the time it is a benign process, meaning that is tissue that is hyperplastic or just growing in excess but not cancer, or it's a cancer that is more benign, called an adenoma. Benign doesn't always mean good news. It just refers to the fact that it is unlikely to spread to other organs. That pituitary macroadenoma is a concept that I think is really important for owners to know, because when we talk about Cushing's disease, 85% of the time, that means their dog has a pituitary or brain tumor, which over time might cause problems if it gets bigger. And so that proportion of patients that over time, and we're talking months, years, longer, if that pituitary gland starts to get so big that it's starting to crowd out some of the space around it, which is brain, we can see a different set of signs develop over time, where most commonly we actually see loss of appetite. So instead of that ravenous appetite, we have a dog that starts to get really picky or finicky with their food. We can see dullness. We can see obsessive pacing, circling, sometimes behavior changes. And these might be signs that this is a pituitary macroadenoma or a larger tumor that's causing subtle or not so subtle neurologic signs. Uncommonly, thankfully, we can see a scenario called pituitary apoplexy, where you are bleeding spontaneously from that pituitary tumor, and that sudden increase of volume of blood in the brain can really cause an exacerbation of local signs. You can have patients that have more severe obtundation, or they can die actually because of so much pressure in the brain. But it's also, I think, worth noting that over half of patients that have a small tumor may end up having a larger, by definition, a macroadenoma throughout the lifespan of that patient, but not every patient is going to have neurologic signs. And that's really important to understand, is that even though the most common form of Cushing's is the small pituitary tumor, even though many of them go on to develop size increases, not all of them are going to have neurologic signs. So that's important to know. In terms of the adrenal-dependent hyperadrenocorticism or an adrenal tumor, we can sometimes call that ACTH independent because it's acting without response or guidance from that hormone ACTH. This is going to happen less commonly in patients, about 15% of spontaneous cases. And in this scenario, you're going to see one adrenal gland, the one that's affected, get bigger over time. And often we will see the other adrenal gland get smaller over time because that's the normal working adrenal gland, and everything in the body is saying, shut off, you don't need to do your job. So the other adrenal gland usually gets small over time, while the affected gland gets bigger over time. About half of these tumors are benign adenomas. Half of them are carcinomas, which means that they may have risk of metastasis to elsewhere in the body. One of the things that we do worry about with adrenal tumors is, especially if you are a right-sided adrenal tumor and you get bigger over time, you can cause compression of your caudal vena cava, the main blood vessel that's returning blood back to the heart, or you can get invasion of that tumor as it's growing through that blood vessel wall, and that can also cause more tumor growth on the inside surface of that blood vessel, or you can get a blood clot from the normal disruption or pressing against the blood vessel. I think it's also important to know that we can cause Cushing's disease. And as an internist, I do cause Cushing's disease because we can see the same signs of that syndrome develop with chronic steroid administration. So if we are treating patients with steroids for immune-mediated conditions, we will see signs pretty reliably of Cushing's develop. And so it's always important to know what the medical history is of our patients. And so I always talk to the interns and residents that I'm training that medical history is so important, because it may not be obvious that this patient has been on steroids long term. It's very easy to ask, what pills are you giving? What liquids are you giving? But if we think about steroid preparations that may be present in creams for the skin, drops for the eyes, in the ears, those are often potent steroids. And if you're giving ear medications daily for months, you may create that situation of Cushing's disease in that pet. The good news is about iatrogenic or induced hyperadrenocorticism is that it's reversible. We just need to withhold or stop steroid production, administration. Often this is the rationale why we want to always taper courses of steroids slowly, because if the body's own adrenal glands don't have to do their job and they're working normally, and they're chronically not doing their job for weeks or months, they do need some time to kind of wake up and do their job. And so if we are on steroids for a long period of time and we abruptly stop, in some patients, they may not be able to get online and working fast enough, and not having any glucocorticoids or steroids in your body can also cause a lot of illness. And that's what Addison's disease is, which is a topic maybe for another day. And then just rarely causes, real odd duck causes of Cushing's disease would be kind of a double whammy if you have both an adrenal tumor and a pituitary tumor, or if you have both adrenals are affected with cancer, because we said it's usually just one adrenal gland. There are some very rare conditions where you can have ectopic tumors, so tumors outside of that axis that are producing the hormone, such as in this diagram here. Pancreatic tumors rarely can cause overproduce that hormone, which tells the adrenal glands to turn on. And then a wacky condition, which is only reported in a few cases, is what we call food-related Cushing's. And this is where we have normal adrenal glands that have abnormal receptors being expressed, receptors which respond to some of the hormones that are made and expressed during digestion, including a hormone called gastric inhibitory peptide. So in this scenario, the patient eats, this hormone is made normally, but the adrenal glands see that hormone and they say, oh, I guess I got to make cortisol now. And so these patients can get profoundly hungrier after eating, or more commonly, profoundly thirsty, peeing a lot more after a meal time. And that's kind of a wacky, really rare event, but it has been reported. So let's talk about more normal scenarios. Who gets Cushing's disease? It's important to remember that this is a disease of largely older animals. So middle-aged to older animals, average age 7 to 10 years at time of diagnosis, based on what papers you look at. And so if you have a 3-year-old dog, if you have a 4-year-old dog that is drinking and peeing a lot, and you say, oh my gosh, I look at all the signs that might have Cushing's disease, I'm going to tell you it's probably not Cushing's disease. Exceptions to every rule, but this is a disease of older animals. Females are overrepresented, and in terms of size breakdown, our smaller breed dogs may have a slight increased incidence of the pituitary form, which we already said is the most common, and large breed dogs may be overrepresented for developing that adrenal variant that happens 15% of the time. What do you notice at home? Well, if you've seen any checklist or client education sheet about Cushing's disease, it's that thirst and urination, which is kind of really key. If I am trying to assess a patient for Cushing's disease and I ask a client, and does your dog, drink and urinate to excess? If there is a pause, if there is a then I'm not going to buy it, because those are the owners that are like, so increased thirst and urination, increased appetite, weight gain, sometimes to the point where we are, pushing little children down to steal their ice cream cone. We're going into the garbage. We have this ravenous, insatiable appetite. Panting, I hesitate to put panting on the list because panting is one of those challenging presenting complaints that can be caused by so many things. But panting can occur because of the effect that cortisol can have on our respiratory drive, as well as some of the mechanics of breathing. If we're developing a lot of intra-abdominal fat and muscle wasting, it can lead to more panting. The abdominal distension and muscle wasting we've already discussed. The skin and hair coat changes. These are non-itchy dogs. They're almost self-treating any allergies because they're making a lot of steroids. But hair coat changes. You have a patient who had an ultrasound or a shave for a catheter, and a year later, the hair hasn't grown back. That can be seen with Cushing's disease. But a lot of times it may just be attributed to slowing down. My dog's just getting old, and owners may not notice that there could be a problem. What don't owners notice? Well, you may not notice signs if you live with the patient. In your case, it's your dog. It's not your patient, but you see them every day, and you may be missing very subtle changes in behaviors or physical appearance over time. So you may not notice if these are slowly progressive changes. Not all of the signs on that list can be present, and sometimes the signs can wax and wane. You don't always have to be all thirsty all the time, but we're looking for general trends. It's important to know that I say, in general, dogs with Cushing's disease are hungry, thirsty, peeing a lot, but they're pretty happy, meaning that they're usually not having significant vomiting, diarrhea, abdominal pain. And so if we do have those signs, it doesn't mean that we can't have Cushing's and something else, but in general, patients with Cushing's disease are not feeling significant discomfort. What about cats? Our first cat slide. This is an uncommon condition in cats. Not impossible, but is much less commonly encountered. Similarly, mean age at diagnosis is about 10 years old. Most of our cats are going to also have that pituitary dependent form, that brain tumor, and most of those are going to be benign brain tumors. Again, low risk for metastasis or spread elsewhere. So the remainder, about 1/5 of cases will have that adrenal dependent form, an adrenal tumor. I would say the most common cause of Cushing's in cats is also going to be iatrogenic, because we use steroids for so many conditions, from IBD to asthma to dermatologic conditions. And so you can make your animal Cushingoid over time because of that, but naturally occurring is pretty uncommon. In cats, we can see the same constellation of clinical signs, but I do think that you often have a pretty profound appearance to the skin coat changes, because you can, not a lot of many cats, it becomes obvious if they're losing their hair, unless they're a sphinx or a hairless cat. But you can see the changes to the skin where it becomes very crepey, very thin skinned. We will often see weight loss with the development of that phenotype, that pot-bellied appearance. Um, but one of the biggest things that I want to point out is that most cats with Cushing's disease are diabetic. So about 80% of cats with Cushing's disease have diabetes. And it is one of the clues that, or one of the things we need to think about if you have a cat who's diabetic, that is very difficult to treat, needs more and more insulin over time, because Cushing's disease can really wreak havoc on diabetic management. Um, Caveat, that means about 20% of patients or cats with Cushing's disease are not diabetic, so it's on us to kind of be aware of these uncommon scenarios. But it can be a very dramatic appearance in a cat. And it's beyond more of just the development of the little fupa, the primordial pouch that a lot of middle-aged kitty cats get. So I just said that cats and dogs with Cushing's are generally not in pain. Generally, it is more of the thirst, the urination, the appetite that is driving the clinical symptomatology. However, we can be at risk for complications because of Cushing's disease that can be more affecting of quality of life and lifespan. So hypertension is a risk that we see with Cushing's disease. And can make it, and those patients can sometimes be can have a hard time controlling their hypertension. Diabetes, particularly in cats, can be a comorbid condition. Remember, we're pumping out steroids, and steroids have that immunosuppressive effect. So we can really make ourselves at risk for systemic infections, urinary tract infections, respiratory, skin, oral infections. And it can be sometimes hard, as particularly for urinary tract infections, to diagnose, because you may be masking some of the inflammatory response that leads to things like straining to urinate or having bloody urine. And so you may be having a patient walking around with a raging UTI, but they're not showing signs of it because of the steroids that they're overproducing. In terms of urinary disease, bladder stones are something that can develop with Cushing's disease, and they're almost always, at least at their core, calcium oxalate stones, which are ones that don't dissolve, so they usually need to be removed. Thromboembolic disease, stroke risk. This is kind of the scary one, because it can be very hard to predict if and when a patient that is at a risk for stroke has a stroke. And there is very little consensus on what intervention steps are appropriate. There are many Cushingoid patients that will not have a stroke, but you can also be at risk for having a blood clot to the lung, or having a spinal stroke, or a stroke in the brain. Pancreatitis, inflammation of the pancreas. Biliary mucocele, which is kind of a bit where your gallbladder gets stoppered up because all the bile becomes super sludgy, are risk factors that we can see with Cushing's disease. And then what can be painful is the condition called calcinosis cutis, where you get calcium deposition on your skin, and that can lead to big, thick, plaque-like, painful changes to the skin that can crack and bleed and get infected. Almost feels like you're part armadillo. You get these plates that can be very difficult to treat. And then rarely some neurologic signs like pseudomyotonia, which is a failure of appropriate relaxation. And so sometimes you're walking very stiffly all the time because of Cushing's disease. Again, that's less common. So let's move on to how do we diagnose Cushing's disease? And I often talk to clients, if you're seeing me for a consultation, that it's kind of like a court case. It's a case where you have to convince a jury, in which case I'm the judge or I'm part of the jury, that whether or not we have Cushing's disease. And the reason for that is because there's not one perfect test for Cushing's disease. And every test has its own fallacies and liabilities. And it's often a scenario where we need to get multiple pieces of evidence that I can say beyond a reasonable doubt, I think your patient, your dog has Cushing's disease. And what that means logistically is that we may take several rounds of diagnostics, and that might mean a couple of visits to go through the tiers of diagnostic testing. And it's kind of important to decide if a patient has Cushing's disease because that does have implications for lifelong management. And we'll discuss management, of course, later on in the talk. And so I do always tell owners that, we want to work methodically and appropriately to convince ourselves or to not convince ourselves that your patient has Cushing's disease. And I'm rarely diagnosing it just based on one test. And because of the rate of progression with endocrine diseases, where things may mature over many months or years, you may have to go back and repeat some of this testing you did a year ago because maybe you were equivocally Cushionoid then, but a year later, you're definitely Cushionoid based on testing. And so some of the key components of testing, physical examination and history. There's some blood tests that we'll go over just briefly so that you have some education about them. There's some urine tests that we perform, and then the role of imaging in helping to make a diagnosis. And so in general, a lot of our tests are either going to be in the category of a screening test versus a discriminating test. Screening tests ask the question, does this patient have Cushing's disease? A discriminating test says, okay, we think your dog has Cushing's disease. Which kind does it have? Again, do we think it's pituitary dependent? Do we think it's adrenal dependent? And so that's kind of how I think about making this diagnosis. Some of the urine tests that you may read about or talk about with your local vet includes a urine cortisol to creatinine ratio. This is kind of a simple test. It's looking at urine and saying, is there too much cortisol? Is there too much steroids in the urine? And the thought process being that patients with Cushing's disease are always making too much cortisol, so there should be really high levels of cortisol in the urine. This is a really good test to rule out Cushing's disease. And I'll say that again. If I do not suspect highly that my patient has Cushing's disease, I might do this test to try to prove that they don't have Cushing's disease, because it's usually inexpensive, relatively inexpensive, and it's easy to perform. You just have to bring in urine that is generally the most non-stressed sample, which is the morning sample. So assuming you have a normal routine, take your dog out for a walk, collect urine, hand it into the vet. And if that cortisol level is low, you've essentially ruled out Cushing's disease for the most part with a pretty high accuracy. It is unlikely you have Cushing's, go no further, continue to look for other causes of increased thirst and urination, for example. A positive result does not mean you have Cushing's disease. It means keep looking, keep testing for it. And so if I have a very high suspicion that my patient has Cushing's disease, I often will forego this test and just move on to maybe more of the meatier tests. Some of the blood tests that are used will include an ACTH stimulation test. This is a test of cortisol reserve. What you're doing is measuring blood cortisol at 2 time points, usually an hour apart, and you're saying, okay, I have a normal amount of cortisol, because cortisol will fluctuate normally throughout the day for most animals, and including ourselves with a diurnal cycle. We'll have normal peaks and valleys. But if I give a hormone, that ACTH, to stimulate cortisol production, am I going to make a little bit more in response, or am I going to make a lot more in response? And if I'm making a lot more in response, that might suggest that we have Cushing's disease. And so this is the 1-hour test. And it is also a test that can evaluate for Addison's disease, which is when you can't make enough cortisol, so the opposite end of the spectrum. It's also a test if we suspect iatrogenic Cushing's disease. I suspect that those ear medications that the dog has been on for years is really what's driving Cushing's disease. We can kind of prove that with the ACTH stimulation test. Not a perfect test. If you look at the sensitivity, it's between 50 and 80%, and that refers to how many patients with this disease you may miss. And so it performs slightly worse for patients with adrenal tumors. And so if I have knowledge from a previous ultrasound, for example, that we're worried about an adrenal tumor, I may not pick this test as my screening test of choice. But it is convenient. It's one test, it's 1 hour. The test that is probably most commonly used by myself or colleagues for evaluating if a patient has Cushing's is called a low-dose dexamethasone suppression test. This is what we call the 8-hour test that requires that patient to be in the hospital all day. This is asking how the adrenal glands function in a slightly different way. It's saying, if I give you a day off, what happens? And so what I mean by that is we'll get a blood sample, and I will give a little bit of steroids, dexamethasone, just a small amount of dexamethasone, but it's enough to do the job for today. And so if you respond normally, you stop cortisol production, or you don't make a lot of cortisol because you've had the day off, you have a day pass. If you have Cushing's disease, you're constantly pushing out and making cortisol. You are not suppressing that short-term production of cortisol. And so we can look at patterns at the 4-hour mark and the 8-hour mark to try to ask that question: does my patient have Cushing's disease? Are they listening to the normal feedback loop, or are they not listening to that feedback loop? Another potential benefit of this test is that in some scenarios, it can serve as a discriminating test. It can give me insight as to whether I think this is a patient that has pituitary versus adrenal tumor. There are caveats to that, and again, beyond the scope of this lecture. So again, it's not a perfect test in and of itself. But it is probably the test that I use most commonly when I have a decent suspicion of Cushing's disease. It does require 8 hours, so that is one of the downsides. It's not a test that you do the day of the appointment. You usually have to plan for that. It shouldn't be run on a sick animal. So if I have a very sick animal, honestly, I'm not going to do any endocrine testing for Cushing's disease. I'm going to treat them, make sure they're feeling better, and then reassess, because it can affect the results to some degree, as can the ACTH stimulation, but we're going to move on from that. The other test that we can do, which is less commonly done, is called an endogenous ACTH, and that is just saying on any given time, what is that hormone level of ACTH in the bloodstream? Because if I have a pituitary tumor, it's just pumping out constantly, it should be really high. If I have an adrenal tumor, the rest of the body is saying, no, 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 stop production, and that ACTH level might be really low. We can do this sometimes if I'm on the fence about what my patient may have. It's a finicky test to run. It's a little bit more expensive than I'd like, and so I don't have too much use for this, often because if I really want to discriminate, is this pituitary or adrenal, I have access to imaging. And with the advent of more readily available imaging, that has become a test we run less commonly. So ultrasound, often a main diagnostic in diagnosis. It can answer a lot of questions that I ask. Some of them I'll list there. Do the adrenals have a normal appearance? Is there an obvious mass? Do we see metastasis? Because we're also looking at every other organ as well. Do I see evidence of blood vessel invasion, that thrombus we talked about? And I can sometimes, with that data, that imaging data, as well as the other data, say, is this likely pituitary or adrenal dependent? Really important to know, it can answer, just because adrenal gland is big, that it's hyperfunctional, that it's overproducing anything. It can't answer, is this enlargement due to a benign or a malignant process? It can't even tell me, is this alone, based on imaging, overproducing cortisol versus other hormones that can be produced with adrenal tumors? It can't tell me, to a large degree, is this very early disease? Because very early disease, those adrenal glands might look very similar to each other. And with adrenal tumors, it may take a long time for one to really look obvious. And with pituitary, where both adrenals get big, it can be a long time before it's obviously they're both big. CT, abdominal CT is another way that we can look at the adrenal glands. And in this view, here's the adrenal gland. It does require anesthesia. It gives you great information, and it can help answer some of the questions that I'm listing here, including is there evidence of thrombus in that blood vessel, which is lit up white here? Does this look resectable if we're going to talk about treatment? And again, it can help inform decision making. It can't answer if the adrenals are hyperfunctional, benign, malignant, or again, is this a cortisol producing tumor or another type of tumor? With CT, we can pretty directly answer the question either with a CT or an MRI, do we have a large pituitary tumor? It requires anesthesia, and we may not see very small tumors, but if we have an index of suspicion of a pituitary tumor, this might help confirm it. Again, it can't answer if that pituitary tumor is hyperfunctional, what type of tumor it may represent, or will it respond to therapy. I'm going to, in the interest of time, just be aware. I'm going to keep talking as long as people are listening, but it's a dense topic, but I also want to be mindful of your time. What about cats? We use the same tests as we do with dogs. The caveat being we will usually use that low dose dexamethasone suppression test as our test of choice. That's the 8-hour test. As an interesting aside, because cats are relatively resistant to steroids, we have to do a much higher dose of dexamethasone. So it's actually called a high dose dexamethasone suppression test dose for a low dose. Ultrasound and imaging can also be very helpful. Okay, so you've made a diagnosis, now what? If I think my patient has Cushing's disease, and this is really an important part of the conversation, do we treat it? And I'm going to just tell you that not every patient that has Cushing's disease should be treated, or maybe warrants the amount of effort that goes into treatment. And so that's a different conversation than I have diagnosed diabetes, you have to treat it, because if you don't, you're going to die of complications. So it is a two-part discussion of how significant the patient's clinical signs are. Do they have some of those complications that might be affecting their quality of life? The type of form of Cushing's disease, as well as a very frank discussion about what treatment looks like in terms of side effects, risks, cost, need for follow-up, monitoring, etc. And that's a really important, that's really what the meat of a conversation is, because in my mind, it's often easy to diagnose Cushing's disease. It's a harder conversation of, is it appropriate to treat, and what is the best treatment for this patient, for this family, for this scenario? In terms of general treatments for Cushing's disease that's pituitary dependent, we'll have some medical options, some surgical options, and some radiation options. And I'm going to just speed through some of these a little bit more quickly, some more slowly. One of the main drugs that you have probably read about or familiar with is a drug called trilostane, or Vetarol is the trade name. And this is a drug which temporarily blocks cortisol production. If we now think of the adrenal gland as a factory that makes cortisol, this temporarily kind of turns off the conveyor belt, because this diagram shows that cholesterol, through a series of just molecular twists and turns, and based on the enzymes it's exposed to, just makes little flips to ultimately become either steroids, steroids, cortisol, another type or class of hormones called mineralocorticoids, or some of your secondary sex hormones. And this is all happening in the adrenal gland. So what we're doing is temporarily blocking production of the factory from being able to make too much cortisol. This is an oral medication that's given once, most of the time twice a day. It may take several months before we get maximal effect, and is generally well tolerated. I will say that sometimes some animals get a little bit nauseous on it or have some vomiting on it, and that needs to be taken into consideration about whether that's okay to continue with that patient treatment or not. This is generally a safe medication compared to what we'll talk about next, but I do think it's important to know that very rarely any patient can have a drug reaction. And one of the drug reactions that we can see with trilostane is, instead of blocking that conveyor belt production line, it can actually cause damage to the adrenal gland. It can cause death to the parts of the adrenal gland or necrosis. And so that, depending on severity, can sometimes be a one-way street where you have completely wiped out adrenal gland function. It's one of the reasons why monitoring is really important, especially monitoring early on in the course of treatment. This also does require long-term monitoring to make sure you're kind of hitting the right level of stopping production. It's that Goldilocksian just right. Too much cortisol, bad. No cortisol, bad. We want that just right. The other medical treatment option is a drug called mitotane or lysodren, and this is a drug which is destructive to the adrenal gland. It's a toxin. It's an adrenal gland poison, and it poisons the layers or causes destruction of the adrenal gland that make primarily cortisol. And so it is kind of a controlled destruction, and this is a little bit more finesse work in terms of how we use it, because we will often send patients home with a higher dose, what's called a loading dose, every day, where they're getting a higher dose. And we're looking for the slight decrease in that appetite, that slight decrease in that thirst, where we then come back and recheck the adrenal gland health, and then we may move to a more maintenance, lower dose, longer term phase. I would say that this is a less commonly used drug these days because trilostane often is effective, and people are afraid of kind of the fact that this is a toxic drug. I'm going to argue, and we'll show you, there's no superior drug, and some patients that do not do well on trilostane do great on mitotane, and vice versa. It just requires an owner that is in tune with the needs of their pet, is able to follow up with the appropriate monitoring. And this is not the drug that you have your house sitter start while you're away on vacation for 2 weeks. A quick word on ketoconazole. This is an antifungal drug that we will use for fungal infections. It does work similarly, or can work similarly, to reduce cortisol production. I am not advocating its use as a first-line drug because it often does not work, but we sometimes need to be creative. And there are certainly data that suggests that it can control Cushing's disease. And so if I have a patient that cannot tolerate these other medications, this may be an option. Again, not my first-line recommendation. Neither is saligeline or anapril, which is a drug that some clients have looked at, that works in the brain to try to decrease that ACTH secretion. I'm going to blow through this slide only so that you know many animals it won't work on. Some animals can have pretty significant GI signs on it. We have to use it very cautiously. And so this is not my drug of choice. But sometimes when everything else has not worked, I will consider other options. A potential definitive treatment for pituitary-dependent Cushing's is what's called a hypophysectomy. That is a surgical removal of the pituitary gland. And so here is our pituitary gland. Here is our pituitary gland, and this is a surgery where you go through the roof of the mouth. And here, hopefully that's not graphic, but it's very fascinating medical technique. We are peeling away some of the muscles, burrowing through the bone, and that little blob right there, that's the pituitary gland. You remove the pituitary gland because if you have pituitary Cushing's disease, it's curative. When it works nicely. What is also important to know is that this is a very technically skilled procedure that is not done in many institutions. It's more commonly done in Europe and Japan. There are some institutions and some surgeons stateside that do it. It doesn't guarantee cure. So it is a kind of a higher invasive, higher cost procedure that may be curative, but it's not always a guarantee. And by removing that pituitary gland, you do need to supplement that patient long-term with some of the other hormones that the pituitary makes. Thyroid hormone, we may need to give some additional hormones to allow water concentration ability. I will mention that it is very uncommon, but if we're talking again, pituitary form, and we're not managing it well medically, one option is to just remove both of the adrenal glands. No fuss, no muss. You don't have the factor to make cortisol anymore. This is, as you can imagine, not a very commonly pursued procedure. It is technically very challenging. You are also condemning that patient to lifelong need to supplement with some of the hormones that it can't make, including steroids. And in my career, I've only been involved with one or two cases where this has been performed, usually to manage it on the other end of the equation. I will mention radiotherapy or radiosurgery. Using radiation for those pituitary tumors, the primary goal is to reduce the size, and it's the size that usually causes the neurologic signs. And so it does not always equate in a dog to reducing hyperfunctionality of cortisol. It's for the patients that we're worried have a macroadenoma that's causing dullness, that is causing attitude changes, behavior changes, the rare dogs that are having seizures from a pituitary tumor. There's a weird cyclical argument because we also recognize that patients with severe neurologic signs may not do as well with this procedure, but it may be more indicated when they're having bad clinical signs. And so it is a weird argument to be made where if we want to be a little bit extreme, we say, well, any patient that has pituitary dependent Cushing's, maybe we should just radiate them earlier on in the process. I'm saying that just as not a recommendation, but it's something that comes up because of that conundrum that we get into. I am going to say again, this is available in places that have the facilities to offer it, and is an entire discussion unto itself. I just don't want it to equate with cure. It's usually not curing these patients as if they're neurologic. We're going to flip the script very quickly for adrenal tumors. And so if I have an adrenal tumor, what are my ways to treat it? So there's going to be a little bit of similarity. As it makes most obvious sense, if I have a single tumor that's overproductive, if I can remove it, that's curative. And that would be the treatment of choice. It is a more challenging surgery, as you can imagine, given its proximity to very vital organs. If there is a big blood clot or thrombus, and that's what this is showing, that there is interruption of the normal blood supply in that caudal vena cava because of a tumor, it does not mean you can't have surgery. Those patients can do just as well. You just need a skilled surgeon to do it. And both laparoscopic and traditional approaches have been described for removing an adrenal gland. If we stage a patient to see if they're a candidate for this procedure, it's also looking for any evidence of distant metastasis, because if we're worried there's lung nodules, I don't think it's really fair to engage upon a major surgery if we're already worried that we're going to have a relatively limited time span with our patient. But surgical removal would be the treatment of choice for a functional tumor in this scenario. I'm just going to pop up. We're going back to adrenal tumor. I do want to say importantly that we can still treat these patients with trilostane and mitotane. And again, ketoconazole is an antifungal, yes, but I'm going to push it away. So even though this is an adrenal tumor, we can treat them with medical options. It's not going to cure them, and it is often a reasonable scenario for patients that are affected. Surgery is not always right for every scenario. So I don't want you to get the impression that if I can't do surgery, what are we doing? Medical management can really help with these patients as well. So I just wanted to mention that. And I'll also mention that there is some very early work looking at the use of radiation for adrenal tumors, not taking them out, irradiating the tumor. And again, that's not commonly done, but it is something that we think about in our kind of our armamentarium of options. This is a complicated slide to go over, and I don't want to overwhelm you, but if you start to look at some of the papers, and these are not all of the papers of survival and prognosis, I just want to kind of have a conversation. So we're looking at pituitary form and adrenal form, and we're looking at studies that evaluate survival with doing nothing, treating trilostane, pituitary or adrenal, mitotane, surgery, radiotherapy. And all of this data are giving median survival times in days. And remember, median is the middle of the group. So it's not including outliers that may do much better or much worse. The take home that I think is important to remember is that for the most part, when we treat a patient with Cushing's, is to treat their clinical signs of quality of life. On average, patients, unless we're doing a curative surgery like an adrenal tumor, on average, patients can live the same length of time whether they are treated or not treated. It's really the quality of life that we often want to pay attention to. And that harkens back to the conversation of, I don't treat every patient that I've diagnosed Cushing's disease if I don't think that that burden of proof is there that they're going to benefit from it clinically. And again, I want to be very careful because there are exceptions, and there are some patients that may not have that increased thirst, increased urination, but if they're chronically getting infections, if they're a high stroke risk, I might treat them or recommend treatment for that reason. Now, I know these numbers are all over the place, and this is not all of the data that's out there, but I want you to understand that there is no treatment difference for pituitary-dependent Cushing's disease with mitotane or trilostane. They both can work. They both can work well. Even if you're using have an adrenal tumor that you're treating medically, they both can be treated. They both can be treated reasonably well. Surgery can be hit or miss. Surgery, you see, has much higher data survival. And absolutely, if you have an adrenal tumor and you remove that tumor, you may be cured. Radiotherapy has a large splay in terms of its survival time. And it's important to talk to your clinician about what your goals are. What are your goals with your dog or cat if they have Cushing's disease? What is going to drive the decisioning? Is it the quality of life? If there's a financial threshold, it's important to have these conversations so that we can help you pick the therapy or intervention that may be best for you. And so again, not every patient that I diagnose with Cushing's I will treat. I'm being very global in this conversation because the devil is in the details, and that's where internists lie. And so case by case, I might have stronger opinions. The other thing that's important to know is that a lot of the censor points for this data will include natural death as well as euthanasia. And euthanasia is a very complicated decision, and that might be guided by financial reasons, that might be guided by non-medical situations. And so I think it's a semi-artificial thing to say that there is an easy answer in treatment of every patient with Cushing's. But what about cats? We haven't forgotten you. Cats, I mentioned, almost all of them are going to be diabetic, and they can be really challenging to manage if they have Cushing's disease. They can also be very challenging to treat as pets and patients because skin fragility can be so common. This is a cat that might have been scruffed or even just handled normally, whose skin falls off because of Cushing's disease. So any cat with Cushing's disease, we handle with literal kid gloves, figurative literal kid gloves, because we don't want to cause injury. Medical management will predominate. Trilostane is the drug that we use most commonly. Mitotane often is not tolerated very well. And the other important thing that I'll mention is that if I have a cat with Cushing's, I want to treat it. So that is a pretty hard rule where instead of dogs, I'm saying maybe, maybe, maybe. Cats almost always are going to be treated because they are diabetic and it makes them easier to manage, or they're having some real complication risks that we had mentioned. Adrenalectomy, or removing the adrenal gland, same kind of considerations that we have for dog. A hypophysectomy, also very rare, removing that pituitary, but it also may cure, as we had mentioned, Cushing's disease. And if it is a concurrently diabetic cat, it also may make their management much easier to deal with. And then radiation with pituitary tumors will often improve the diabetic management and can improve neurologic signs. And so diabetes, a cat with Cushing's with a pituitary tumor that's diabetic, that's a cat that actually radiation may play a higher role for improving the diabetic management. Again, you're still managing the Cushing's, but you may be able to better manage that patient systemically. So there are some differences. Survival and prognosis I mentioned, and I want to be, again, respectful of the time. With cats, often a poor prognosis if they're not treated due to complications. And often cats are older when they're diagnosed and they may have comorbid conditions that limit survival times. But my general blanket statement is if you're that rare cat that is cushingoid, I'm almost always going to recommend treatment. And that's, again, a different conversation than a dog. So some canine treatment take homes. Not every patient needs to be treated or immediately. Sometimes this is a discussion to have over weeks or months with your veterinarian. Treatment is largely centered towards improving clinical signs and quality of life with the dog. There's no significant survival difference between using trilostane and mitotane, so don't stress too much about having to pick the right drug. We're going to help you, but they are both tools in our toolbox. Surgery can be curative unless it isn't. Again, there are some caveats there. Radiation may be helpful unless it isn't. I'm being a little bit glib because those are more serious conversations to have, and it's a complicated one. And it's really hard to account for euthanasia and as sensor points in a lot of these studies. So I don't gravitate too much on the numbers. You know, owners naturally want to have numbers of like how long if we treat, how long if we don't treat. You just have to understand how we get some of that data. In contrast, feline take-home points, most patients will need to be treated to improve quality of life as well as clinical signs. Trilostane is going to be the most commonly used medication. Surgery, again, surgery may be indicated again for those adrenalectomy cases. Pituitary surgery is very hard to find places that do that readily stateside. And then radiation may play a role for that diabetic cushingoid patient that's really hard to manage with his diabetes. And with that, I've taken what's probably 6 hours of individual lectures, tried to make it into one lecture that is not too boring, hopefully a little bit helpful. And I'm happy to take any questions.
Thank you so much. It was very helpful and very thorough. I know it's a complex topic, and we appreciate you breaking it down so clearly. We have some questions, so we'll get to as many as we can. Um, we had a question about, is there a genetic marker for Cushing's?
Great question. I don't think there is. I think it's going
Okay.
to be one of those multifactorial diseases, which means that there's probably a genetic component. It's probably multiple genetic inputs. And to my knowledge, there is no screening test to say, yes, your patient, your pet, my pet,
Yeah.
is going to develop Cushing's disease.
Okay, great. Okay, we have two litter mate terriers with Cushing's pituitary etiology, several friends' dogs with Cushing's. Do you think there is an increased incidence overall?
I don't think there's an increased incidence. I think there's probably an increased awareness in the general public about the disease. And so there may be more diagnoses made because we have informed clients that are talking with their veterinarians and saying, hey, these are the signs we're seeing. And, historically, I guess I can't speak towards historical data. We don't think that this is a disease on the rise. I just think it's more awareness and probably earlier diagnosis and hopefully earlier intervention.
Okay. Right. Are there preventative measures
Not that I'm
to
aware
take?
of.
Okay.
Not that I'm aware of. I mean, I think that the bigger question of epigenetics and how genes can be turned on or off over time, including due to the influence of environment, drug exposure, pollution, et cetera, that's kind of a huge question for many diseases, but there is nothing that I'm aware of that is going to be a risk factor environmentally.
Okay. I've read that it's important to bring my Cushing's dog to an internal medicine specialist, not my generalist veterinarian. How important is this? Should I seek out a
Fair
specialist for
question. I
this?
think it's a conversation to have with your general practitioner. There are absolutely wonderful general practitioners that are very comfortable with the diagnosis and management with. And if they are comfortable, there is not always a need to see an internist. I think that because internists live in this world of dealing with these types of cases more commonly, I can certainly see the benefit from my end of seeing an internist for these conditions, maybe for nuance, maybe if we have a case that's difficult to manage. But I would not say by rote it has to be a specialist. I think it's a conversation with the comfort level of your local team. I do not
Okay.
need to see every case of Cushing's disease.
I know we were saying now you're going to be the Cushing's expert after this, but, I know, okay, if adrenals
I work
you
with a
do
lot
d
of local vets that do a
okay,
fantastic job with management, so this is
okay.
not a "I'm so special, come to me." I'm a nerd and I like this stuff, that's
Yes. Well, you do a great job explaining. Thank you. Okay, does an elevated ALP, that continues to increase when tested suggest Cushing's?
it could. I specifically didn't talk about some of the blood work changes
Mhm,
because, again, that's a whole nother kettle of fish. It can. About 95% of patients with Cushing's disease will have an elevated ALP, which is one of your liver enzymes. However, that is not a specific marker for Cushing's disease, and so it starts the conversation of how does that patient feel at home? Do we have clinical signs that could fit slowly towards that workup? There are a lot of other conditions, some benign, some more serious that we can see with elevated ALP. And so that's where I get a lot of referrals to try to sort out the liver changes on blood work with imaging, kind of kissing the endocrine end of things and see just how do we triage and organize our thoughts for this patient.
okay, great. Are there any breeds that are overrepresented with Cushing's?
Unfortunately, no. Any
Mm,
patient, any breed can get it. There are, I'm going to keep it simple like that. Some people might have
okay.
different opinions, but I think it's anyone can cook and anyone can get Cushing's.
Okay, okay. We had a few questions about asking why the panting in Cushing's dog, why it happens mostly at night, and what about it with the regulating body temperature?
Yeah, probably a complicated answer that I'm going to just pretend to know. But I think that it has to do with the effect that cortisol has on our normal kind of diurnal wake and sleep cycles. I think there's some neurologic input that is occurring on a brain level. I think that because we may be having a decreased compliance or our ability to expand our lungs if we're lying down for a while and we have more obesity and increased pressure from our liver, we might kind of I liken it to when I try to walk up 2 flights of stairs and then have a conversation. I'm kind of good in keeping my and then I'm like, give me a second. It's kind of like that too.
Okay. I have a pituitary dependent Cushing's dog. Should I request organ ultrasounds from my vet to see the state of his liver and organs and other potential issues?
Um, you're 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 talking to a biased audience because the answer is for me is yes.
Mhm.
Because I think there's a tremendous amount of value in getting imaging because these are patients that are generally older. They may have other conditions where Cushing's is not the main problem, and we may uncover a liver tumor, a kidney problem, blah, blah, blah. So I do think that getting imaging as a non-invasive diagnostic can help with our understanding of Cushing's, but also looking kind of more globally
Okay. Okay.
at patients.
I knew we were going to get, I have an Addisonian dog at home. Could Addison's potentially turn into Cushing's from prolonged steroid use?
Yeah, that's a really good question. No, if you have Addison's disease, and we're talking about the most common forms, that is an atrophy of the adrenal glands. They cannot make cortisol over time, and so you will have to supplement them. You are not going to make them have Cushing's disease naturally, with the exception, dot, dot,
Mm,
dot, if the dose of cortisol, glucocorticoids or steroids that you're giving is too high, you're going to have Cushing-like signs. And so if you're an Addisonian patient and you're having a lot of thirst, urination, appetite, then you talk to your vet about, is the dose appropriate? Do we need to tweak things?
okay, great. Well, maybe a topic for another webinar in the future, we hope. Um, okay, well, I know we're a bit over, so I just want to thank you so much for really helping to demystify Cushing's syndrome for everyone. It's a topic that we have wanted to do for a long time now, and we really appreciate you taking the time to address it and address it so clearly and thoroughly. And then I just want to thank Kimberly Young for helping to organize this event and all of our events. And a very special thank you to all of you for taking the time to join us today and for your continued interest in our programming. Um, We really appreciate it, and we look forward to seeing you at our future events. Okay, have a great night, everyone, and thank you.
Yeah, thank you so much for showing up. I'm sure you have better things to do with your lives, so I'm very impressed that we're all now on Team Cushing. So thanks a lot,
Absolutely.
everyone.
Absolutely. We had a great turnout. So thank you again, Dr. Slade, and thank you, everyone. Take care. Good night.
Have a great night, everyone.